In Singapore, maybe they might prefer a little bit more cooler water. It's not so much of an issue. You know what I mean?
The water's always warm.
Give me the cooler water.
Hello everyone, so welcome to another episode of The Bite Angle. I'm Dr. Justin from the Dental Designs Clinic, and over here we have Andrew Terry from Australia, all the way from Australia.
Indeed.
So welcome, Terry.
Thank you very much for having me, Justin. Great to be here.
All right, Andrew. So Andrew is actually a senior lecturer in dental hygiene at the newly established Faculty of Medicine in Sydney.
Correct.
All right. And he teaches both Bachelor of Oral Health and also DMD, so Doctor of Dental Medicine.
That's right, yeah.
Programs in Sydney as well. So he often teaches about oral hygiene instructions, periodontal treatments, and whatnot. And also he works, I don't know how you find time.
Yeah.
But you also work in a private practice each Friday.
Correct.
And you also have a special interest in compassionate care for HIV and Hep C patients.
That's absolutely right, yeah.
Wow, okay, and then well, you're really dedicated and passionate.
Yeah.
And you work in a lot of countries. Which countries?
So when I first trained as a dental therapist, basically in Australia, and that was in Brisbane. That was a long time ago. That was about 33 years ago.
Okay.
So I worked in Brisbane basically, but first I was transferred up to North Queensland, where I worked remotely for a while, for about a year, and I worked on Palm Island Aboriginal community when I used to fly over and back to work every day in a little 5-seater aircraft.
Every day?
Yeah, for about 2 months or so. I also worked on Magnetic Island Primary School there for about a month, going back and forth on the ship. Then eventually I moved back to basically Brisbane for about 3.5 years, worked in the school dental services in a bit of a lower socioeconomic area. And we did school toothbrushing programs, lots of drill and fill at that point in time because the caries rate was higher. After that, I moved to London to study dental hygiene at Guy's Hospital. And then after qualification in London, I then stayed in London for about 2.5 years to work as a hygienist. Then from that point, I wasn't quite ready to move back to Australia. Yeah, it was a lot. Yeah, then I moved to Switzerland. I worked as a hygienist for about 6 years in Switzerland, learnt a bit of German. And then from that point, I moved back to Australia, where I've been based for about the last 20 years, in Sydney for about the last 18 years, 19 years.
Wow, okay. And like, I mean, let's start off now. Like, since you traveled so many places, like, do you see a difference in like oral hygiene culture or people's perspective of teeth?
Yeah, definitely. Like particularly in the UK, there was the way like the appointments were shorter at that time. Like it was mainly half an hour for a hygiene appointment or a standard checkup clean appointment. Whereas when I went to Switzerland, it was probably a bit more like Singapore, and Australia was more like the hour for a standard hygiene sort of appointment for your patients. So and also just the approach, like the Swiss at that point in time were quite heavy smokers, and unusually smoking was quite cheap over there. You know, it was like about
it's a very European thing, I think.
Yeah, it was a real European thing. And Australia, probably less so, you know. And then you've, over the years, because I've been in the industry now for about 32, 33 years. So, you know, the advent of vapes has come on in previous years, which is thankfully, I think, forbidden here in Singapore, which is a very good thing. Because all the research around vapes right now is not very good. It's almost worse than smoking in terms of carcinogenic materials.
Does it stain?
It can, depending upon the actual vape they have. And also with a lot of the vapes, they have lots of carcinogenic chemicals in them. And although the vapes are actually advertised as not having nicotine, there was actually even an analysis was conducted recently, and they were actually, even though they say they don't have nicotine, they do have nicotine. So it's still addicting people. So even the Australian government now has moved to limit the sale of vapes quite quickly to try and prevent that from happening. But obviously there's illegal operations that still occur, unfortunately.
Yeah, and there's a lot of like substances that like make you like hallucinate and high and all that stuff.
Yeah,
as well.
Absolutely. Yeah. So that's where I'm glad that Australian government's made that move. It's definitely a good healthcare measure moving forward to try and get our youth off that. For
strange
sure.
Because obviously Singapore bans it, so we hardly see them, or rather it's like not an open thing. Yeah. So I don't really see the effects of like vaping.
Which is a good thing in Singapore. But generally, you can sort of see that there are, usually we've had some incidences where some young men, for example, they're vaping all day, and they end up in hospital with almost lung conditions where actually their lungs are partially collapsing because of the type of chemicals that are in there. So it's rare, but it does happen.
It sounds like it's more harmful than smoking.
Well, that's what exactly. That's the emerging evidence around vapes. So it's a wonderful thing that in Singapore, it's just not here because you just don't want to get the opportunity to get into that position. The illusion
it's a very political thing as well.
Yeah, definitely. The illusion was it was harmless at the start, but now we know it's actually almost doing more harm than cigarettes.
Okay, cool. And then so in Singapore, it's a bit different as well because, in Singapore, from my experience, everybody that comes here for an appointment, for a checkup, they want a clean done at the same time.
Yeah.
So, you gotta, it's 1 hour, but it's not really 1 hour of hygiene. It's like 20 minutes or 30 minutes of consultation and then half an hour of clean. So it's always that. And the patients are not so happy if they, why am I just talking to you for that hour and then I got to come back for a clean? So we always have to pair it up together. It's just a cultural thing, I guess.
Yeah. So in Australia, generally the way I work in private practice, where I've been working for about the last 20 years in that practice, I've been associated with it. So basically, usually when it's a new patient, we'll say, well, you'll need to have a consultation with the dentist first. And that will involve an OPG X-ray, some bite wings, intraoral camera. We'll discuss your needs, your wants, what's happening. Then we'll send you for a clean afterwards. So set the expectation up. This is going to be about a 90-minute commitment. So then after that, you'll see the hygienist afterwards who will look at the X-rays, review your oral hygiene. They'll assess your periodontal status, and then they'll make a treatment plan appropriate to what's needed for that.
That's great. That's great. Yeah.
So it's a good way to frame it beforehand. But I understand. But it's a good way to always set that expectation up when they pick up the phone to make that appointment with you.
Yeah.
If you're a new patient, this is what we recommend on best practice principles.
Yeah. Absolutely right. If I could just do that, that would be really, really good. It's just that the perception is so powerful.
Yeah.
That
so the community here are conditioned. Yeah. This is what. So that will take time to change.
Yeah. So we try to do it as well actually. So it can get better, I guess.
Yeah.
Interestingly, I was telling you, I was actually I studied in Melbourne in Australia.
Yeah.
And the culture is really towards hygiene. It's really a big thing for in Australia. And I think that's brilliant actually, because in Singapore there's a preference to seeing the doctor for a clean.
Yeah.
And often we know that it's not the doctor is not specialized, I would say, in hygiene work.
Yeah.
And I think that Australia moving towards hygienist as a primary role for hygiene work and things like that is a much better thing as well.
Yeah, and basically even because I teach in the dentistry program basically as we mentioned, and so the way I sort of like to convey that to the dentist students is, it's good to set up your hygienist, your oral health therapist as a support person. And the way you want to frame that to the patients is they get a bit more training in this department, in this speciality than I do. And therefore, what you want to encourage your patients to is see the hygienist for this purpose. And then you can utilize the more specialist training you've had in pros, crowns, all of that, which is actually going to generate income for your practice, and that's better utilization of your skill set. And then you have the hygienist that basically, or the oral health therapist, they'll do the checkup, the x-rays, you come in, and also you oversee, always shake hands, how are you with your patient? So don't lose contact with your patient. But then also you train your hygienist or oral health therapist. It's like, when you identify this is the sort of carious lesion I'm more likely to restore, this is what I'm more likely to monitor. And then what I do with the dentist I've been working with for 20 years is I know how Trevor or David, who'll work, I've been working with forever. And so basically I will sort of say to the patient, I don't say that's definitely going to happen. I say, look, it looks like there might be something going on here. I'm going to get Trevor to come and confirm. And then they come in with the authority to sort of go, well, yes, I think, Andrew's right. We need to do it. But I know in my mind, but usually 90% of the time I'm right, but that 10% of the time
but you don't want to
right.
disagree with
him
or
I don't want to step on their shoes, right?
Yeah, you're right.
So it's a good way to
That's
actually
really good,
have a calibration meeting with any auxiliary staff that you have and really define the conditions about how you want to work as a dentist. And it can really be a fruitful relationship for a private practice.
Really, really good, really good. And I think that the hygienists actually have a much better rapport in building compared to the dentist, because
they have longer. They
just
have
a longer treatment time,
exactly.
right? And it's like a very regular thing. It's like a 3 months, 6 months kind of thing.
But it's still important for you as the overseeing dentist, particularly in Singapore with the regulations. They must work in a professional, structured relationship with the dentist to always be there. Go in and do a meet and greet. How are you? How's the family? A little personal touch so that you're still omnipresent. and there is the overarching leader of the practice. You know what I mean?
Yes, I know what you mean.
They can still, the hygienist can report back to you. And I'm sure it's common practice here in Singapore as well. We always do like a morning huddle for about 15 minutes, go through our patient lists, and we'll go, I remember this patient last time, they're recovering from cancer. Let's come in and give them a bit of love, give them a bit of attention, you know? Build that professional relationship, because at the end of the day, they come to the dentist for care, capital C-A-R-E, and then it's more about if we show they care, they're going to tell 10 friends that we're fantastic. If we treat them a bit like a number, they're going to tell 20 people that we treat them like a number.
Yeah, you're right. No, absolutely right. I think the biggest thing in dentistry is, apart from all that marketing, is actually showing care.
Absolutely.
It's the genuine, sincere care that you really want to have, and patients want to have that, right? As well.
Absolutely. And look, when we're lying back and our mouth is open, we're feeling very vulnerable. So it's a lot of trust they convey in us, and it's something we need to respect. Sure.
So, no, absolutely right. Okay, cool. So, you know, you're in Singapore for the IDEM, and you gave a lecture as well.
Correct, yeah.
What was it regarding again?
So I did basically for oral health therapists or dental hygienists, dental therapists, just some awareness raising about what they would need to ask patients if they identify as being HIV positive or Hep C. We discussed the latest treatment modalities, some of the events that are happening in the future in terms of advancements in terms of potential vaccinations being developed even for HIV. So we talked a bit about that literally for that hour at IDEM on Saturday afternoon.
Wow, that's a lot. And the interest was pretty good, right?
It was pretty good. I mean, because usually when you're a little bit of later in the afternoon, usually as they say, if you're speaking at a conference on Sunday afternoon, it's called conference death. You know, there's usually no one turning up. Well, Sundays, you know,
family
people might be
day,
going, exactly. It's a family day Sunday, or they might be going to church, for example. But I was lucky enough to be on a Saturday afternoon, so I still had a good interest. So it was good. It was good. I had some good questions afterwards as well. So
I mean, in Singapore, I don't know about in Australia, but it's still patients are not really keen on telling
disclosing
as well.
Of course. There's that
there's
shame
social
element.
stigma to it as well.
Absolutely.
And a lot of even in healthcare professionals as well, and I would say in dental professionals, if it's like HIV positive or Hep C, there is a tendency of the healthcare professional to actually refer to the institutions like the hospitals to get their treatment done, just because of sort of the unknown, right? Like so I think educating them would be a great idea. And,
and look, even for your listeners, podcast listeners and viewers, basically, a couple of things you could ask. If they've identified as HIV positive, what you want to ask them is, when was the last time you had your set of bloods taken? So usually that could be anywhere between 3 or 6 months, depending upon what medication they've been taking.
Do they need to regularly take blood tests?
Yes, that's right. Okay. So generally, the medications these days come in there's usually 4 drugs within one tablet. And those drugs actually prevent the prevention or the cycle of the virus production at different points. So entering into the cell wall, replicating in the cytoplasm, penetrating the nucleus, exiting the cell wall. So it's targeted for that. Also now there's even injectables. So injections are one on either side above the buttocks every 3 months, and they don't have to take tablets. So there's variations of the medication application these days. So if you are confronted, not confronted, that's probably a bit of a challenging word. If you have a patient who identifies as HIV positive, thank them for being honest and ask them and let them know we're going to treat that with absolute confidentiality. And simply say, when was the last time you had your bloods? What was your viral load? If it was undetectable, which is less than 20 copies per milliliter of blood, the chances of you getting something from a needle stick injury is virtually impossible. You actually have people the
virulence factor.
Exactly. For example, I have 2 patients, a husband and wife. Basically, the wife unfortunately got HIV through a needle stick injury many years ago, back in the late 70s. But she's on her medication, and so that's what we classify as a serodiscordant relationship. So her husband is HIV negative, but they have relations, but she is basically HIV undetectable viral load, and she will not pass it on to her husband. There's evidence and research to back that up. So if you're a dental care professional and your patient identifies my T cell count is well above 500, between the 500 to 1300 mark, which is a good healthy T4 cell count range, our immune system's primary defender, and their viral load is undetectable, and it's been like that for a long time, the chance of you getting something from is virtually nothing. But, in Australia, and I was just checking this with the MOH, the Ministry of Health here, it is highly recommended that a patient disclose their HIV status to you, but it's not illegal for them not to, because we adopt these days what we classify as universal infection control procedures. We treat every single patient like they may be potentially
HIV.
carry a bloodborne virus.
Yeah,
That's right.
yeah.
So what's important, and we always say this to students in Australia, and I mention this to even the participants at the convention in the lecture, was if you ever have a needle stick injury, do make sure you always go back and go to your patient and declare, oh, look, I've had a bit of a needle stick injury here. I just would like to revisit your medical history. Any changes that you'd like to identify? Because at that point, it is a legal requirement for anyone that has a bloodborne virus, because there is a potential for transmission.
Oh, okay.
Even if it's undetectable viral load. So therefore, that is a legal trigger where the patient actually, I need to declare to you, I'm so sorry, I was scared to tell you, but I actually have some HIV, okay? It's undetectable. And then usually they might open up. This has circumstances happen to me. And then basically what can happen, and will be available here in Singapore, is post-exposure prophylaxis. So if you prevent to any usually accident emergency or a specialist HIV clinic here in Singapore, within 72 hours, then you'll take your baseline bloods, you ask your patient to take the baseline bloods as well. You, as an operator, you start a course of post-exposure prophylaxis. Usually it's a medication called Truvada. And basically that will then further prevent the person who's been potentially contaminated with HIV, from actually seroconverting by a further 84-85% reduction. So it really does almost stop the transmission entirely.
Yeah, so I think that's a really good point you raised. The thing is that I think the first thing would be when the dentist or the hygienist or the dental operator gets a needle stick injury. The biggest thing is that they are like shy to tell the patient that they had a needle stick injury. People often like cover it and say, hey, because it made me look bad, right?
Yeah.
And then then you got to ask these very difficult questions to ask. And so that's what I personally, people
would find
face, because you'd be like, hey, I did something wrong, and then So that's one.
Exactly. I always would tend to frame it. Look, accidents happen. I've just had a bit of a slip here. I apologise. That's nothing to do with you. I just want to revisit that medical history. There's nothing that we need to be concerned about in that sense, or any recent events that we need to be aware about. And it's the way you gently frame it as well.
You're right.
It's like, I'm human. Unfortunately, I've made a bit of an error. But just to because there is that perception of patient. You should know what you're doing, but errors do happen.
Yeah, absolutely.
What happened with me was I was giving an IA and block. The patient sneezed, and then it went into my finger. So it was an involuntary reaction, right?
Yeah.
And then basically said, "Oh, I've got to tell you." And okay, that's okay. And having the knowledge background, they were actually more worried about me.
Oh, that's nice.
Yeah. And I'm like, oh my God, if I've given this to you, I'm going to be so.
So was this patient a HIV positive?
They were, but they didn't declare it to me until I told them I'd had the needle stick injury. But then they said, I'm undetectable viral load. These are the medications I'm taking. They were like, I'm going to go get a blood. And I said, it's fine. I still see this patient to this day. It's fine.
Oh,
I didn't, I just got to humanize the situation. We're at the day they're a human, not a virus. And just remember that we're healthcare
That's a good one. That's a good one.
We're healthcare providers. So we're dealing with humans, and we're all fallible and have our fallibilities. And so, trying not to make them feel bad. And I knowing what I knew, I said, look, it's okay. I'm going to get some post-exposure prophylaxis. You've mentioned you have an undetectable viral load. I'm not really that concerned. But look, thanks.
Yeah.
Then he phoned the practice every week. Is Andrew okay? Is Andrew okay? And I phoned him back. It's
that's
okay.
Nice of him.
And then I phoned him and said, I'm all good. It's all clear. And then he was relieved. And I said, I'm looking forward to seeing your next appointment. All right?
Yeah.
And he was like, oh, thanks so much. So again,
that's
handling
nice.
run towards the issue instead of run away from it is always a good thing. And treat people with humanity, I think, is a good thing. Yeah.
And like, what about the meds? Because there's a rumor, or rather a gossip, that says that the meds are really quite strong, and like there's a lot of side effects.
These days, that was the historical meds like AZT.
Yep.
A lot of the meds these days, it's almost like they're taking a multivitamin tablet in the morning.
Okay.
Like I said, it's one big tablet or moderate-sized tablet with 4 actual drugs contained within it, which disturb the viral replication. All those are identified.
No, but the meds for the prophylaxis.
As in the post-exposure prophylaxis.
Yeah.
People can react to that in different ways. When I had it, I'd had a mild stomach upset for 6 hours, about 4 days in, and then nothing.
Okay.
No problem.
Quite
The
cool.
same with patients that are taking Hep C medications. The latest Hep C medications have basically an ability to clear that virus by around about 95% chance of clearing the virus entirely, compared to the older medications, which are extremely hard on the body. So
Yeah, that's what I heard.
Meds, the latest
And
Hep
you
C
got to take
meds
a
are
lot of
great.
meds as well. Like,
Yeah.
keep on
It
popping
was
them.
the
Yeah.
interferon, ribavirin, all those ones. But these ones, it's just the one tablet a day. And it will depend, the tablet will be prescribed by the treating physician, will be based upon the kind of virus they have, the subclass, that's like, genotype 1, subclass A.
Also, the blood test really matters.
That's
a lot.
right,
Yeah.
exactly. And then if there's been any cirrhosis of the liver, they'll modify the medication based upon if there's any cirrhosis of the liver as well. But also with HIV and Hep C now, I don't know if you've heard about CRISPR-9 technology. So this is where they extract part of a gene.
splicer,
That's right. So CRISPR-9. So why they usually can't clear hepatitis or HIV viruses, it usually hides in the extremities, the ends of the fingers and the toes. So with the CRISPR-9 technology, basically what they do is they feed that and they're trying to clear the virus that way. But they're developing, and this is something from the COVID-19 pandemic, they're looking at HIV Hep C medications from an mRNA technology.
It's like the COVID thing.
That's right.
Yeah.
So with that coupled with the CRISPR-9 technology, they're actually being able to, the CRISPR-9 technology, that is actually flagging the virus to the immune system in the extremities. Then they're trying to get on top of it with mRNA vaccine. One has been developed, but actually they cause a lot of hives, so they have to go back to the drawing board a bit. That's not an acceptable amount, but it did help to prevention by around up to 80%, I believe. And that was a clinical trial that was published late last year. But that's still a work in progress. So to watch this space for in the vaccine in the coming years.
That's great. That's great. Wow. I mean,
particularly for
there's a
dental
lot of
professionals.
development. There's a lot of
it's moved quickly. And again, that's one of the only good things that came out of COVID, I guess, was is the mRNA vaccine
it's
and a few other
controversial,
things.
man.
Not much good came out of it. Let's face it. It was a pretty horrific time across the world. I think Singapore managed it beautifully, as Singapore generally does. Really good, efficient. Pardon me. But it was not a great thing in Australia. The lockdowns and everything were terrible.
There was a long lockdown from Australia, if I'm not wrong.
Yeah.
Okay, cool. So let's just move on.
Sure.
No, thank you so much for the information. It's so great. Oh, actually, let's stick on the topic still. I just want to know: are there any dental effects of HIV and?
Not these days. Generally, it's almost the main thing they may have for hepatitis or HIV medication is potentially a little bit of dry mouth. That's about it. There's no oral manifestations. What I spoke about in the lecture was as well, what you may get a presentation of failing a medication. If, for example, I had another situation clinically where a patient hadn't actually gone to their blood test, they'd skipped it from a 6-month to a 9-month mark, and just per chance, their medication they'd been on for about the last 8 or 9 years was beginning to fail. So therefore, there was actually a bit of a, basically it's like you could break it down into the 4 classes. So this is where you've got either a candidiasis, a fungal infection,
so the
bacterial.
immunocompromised.
Yeah. So, and then what a flag would be is, let's use candidiasis as an example. A little bit of angular cheilitis, a bit of candidiasis on the
fungal
inside.
infection.
Yeah, fungal infection. That's right, fungal infection. So you treat it,
Yep.
but it keeps coming back. You treat it, but it keeps coming back. The immune system is not getting on top of it. So it's recurring infections. That's where a point you might want to go with your patients. Oh, when was the last time you went to your doctor, had a full blood workup? When was the last time you had your meds checked, all that sort of stuff. So you're managing conditions like even ulcerative gingivitis. You treat it with your chlorhexidine, your soft brushes. Even if you're a dentist, you're prescribing some metronidazole, 200 to 300 milligrams over a 3 or 5 day course. And then basically, but it keeps coming back. That's a flag that, not even HIV, but there's something going on with the immune system. Yeah. The body's not getting on top of this infection, which when we initially treat it, should actually be managed by the immune system. So that's sort of maybe an indication. So that could be fungal, and like a candidiasis, basically ulcerative gingivitis, bacterial, oral neoplasms that keep coming up, and you have to send them off for a biopsy for that diagnosis. So a few things like that, they just sort of keep returning. That's where, with treatment, that's a bit of a flag that something's going on with the immune system.
Okay. So, but there's no that's mostly immunity driven,
Correct.
right?
But there's no real oral manifestations of the medications they take, or any oral repercussions apart from maybe some subtle dry mouth, which we just simply make sure that they're keeping themselves well hydrated. We do our regular X-rays to check for caries, white spot lesions, etc., and respond as a normal patient. Yeah, because if they have an undetectable viral load in their T cell count, it's pretty much a normal immune system.
Yeah, you're right.
It's a normal immune system. Yeah.
Okay. Cool.
Yeah.
All right. Let's move on. So shall we talk about? Okay, so we're gonna talk about biofilm now. So, in Singapore, biofilm is nobody knows what's biofilm.
Yeah.
Right? People think that biofilm is like toilets.
Yeah, exactly. It's like we have to go dental plaque. We have to use the old term and then marry it to the new term.
Yeah.
We call it biofilm now, oral biofilm. Yeah, exactly.
Yeah, and so what's the, in Australia, you guys are at the top, really the top of the oral hygiene, sort of the regime. What's the current recommendations for oral hygiene now?
In terms, basically, I generally, this sort of a touch to teach philosophy. So this is where generally, when we train students at the University of Sydney, and this is an emerging thing also around the other universities as well, is where usually we have that big plastic model with a big toothbrush and show them on this is how you brush. But if actually you then try and get the patient to replicate that in their mouth, it doesn't really work. Yeah. So if you think back to when you were studying dentistry, how did you learn how to do periodontal instrumentation? How did you learn how to drill and fill? It was repetitive, muscle memory, haptic feedback mechanism. So what we encourage the students to do now, and also initially, is disclose your patient, okay? Provided they don't mind, right? Because seeing is believing. So simply using a disclosing agent, either a 2-tone or a 3-tone. If I can mention one, GC Tricolor Gel, I like that. I'd have no affiliations with GC. I just happen to like that. I just want to mention that. The reason is with that one in particular, like the 3 colors represent, if you disclose your patient, then you get them to rinse out. Then generally the light pink biofilm is less than 24 hours old, and that basically is fairly innocuous. Dark blue is usually basically more periodontopathic. It's around about 48 hours old or a bit older. Then they have a light blue one, which identifies the biofilm or pH of the biofilm is about 4.5. And we know the critical pH is 5.5. So we know underneath that light blue biofilm, there may actually be potentially even a white spot lesion. So that takes you on a keriogenic and diet sort of conversation with the patient. What sort of toothpaste are you using? Are you spitting out but rinsing? Do you need to not do that? Do we recommend a stronger fluoride toothpaste or a calcium phosphate paste they can apply in their mouth? And all the other gels, basically disclosing agents, it could be single tone, which is either there or not, or most of them on the market now are sort of 2-tone, which are the pink and the blue. But I just like that other one I mentioned. I won't mention it again because I don't want to get into brands. But that's sort of, I like it because of that actually element it has. It gives you a periodontopathic and a keriogenic conversation with the patient. So it's dual. That's obviously we're holistic oral health care providers. So what I tend to say to the patients, I'm going to do a bacteriological test. I don't say I'm going to disclose your teeth, because disclose is like, I gotcha. So generally when I see the patient for a standard hygiene appointment, I check their medical history. And then that's where we know oral biofilm is linked through lots of studies, a bi-directional relationship with diabetes, blood pressure, heart disease, all of these sort of elements. So if they present with something in that sort of medical history, which oral biofilm is linked to, I will gently remind them about that. So remember, the mouth is connected to the whole body. Okay, so this is going to connect it to your toes, your head, your brain, everywhere. So if this has a bit of ill health, it's going to affect your general health. So I like to have that sort of conversation. Then usually after that, I've usually asked them open-ended questions. What do you do for your oral hygiene at home? What do you like to use? Do you use a manual brush or an electric brush? Do you use anything to clean in between your teeth? I step away from that approach of closed question. Do you brush twice a day with a manual brush? Do you floss once a day? I want to know what works for them. Further to that, what is their routine? Are they night shift workers? Are they nurses? Are they a mum looking after 3 kids? Are they busy? So that the time we're going to recommend oral hygiene to our patient may vary. When in the day suits you to clean your teeth? When do you have a moment for yourself to do it?
This is like a gym instructor.
Yeah, exactly.
Like you're telling them customized treatments.
Yeah, exactly. It's an individually tailored oral hygiene prophylaxis approach. So look at them as an individual, have a conversation with them, and they're more likely to accept that message. And then it's like, okay, I prefer an electric brush. Which one have you used? Okay, and then basically you get that information. Then I'll say, okay, well, let's see how you're going. So I'm going to do a little bacteriological test. This is what the colors mean. And then I lie them back, apply the gel. I sit them up into a supine position. Don't say anything. I've seen what's been going on. I put the mirror in front of them and say nothing. Because I don't want to shame them. I don't want to make them feel bad. But the colours will actually say and tell the story of what's going on. They go, oh, I've got this, I go, reassuring, gentle touch underneath the elbow as a neutral area. It's okay. I'm here to help you. Let's work today. Firstly, maybe just on your brushing technique. Let's do that. So in Australia, part of my reminder message when they're confirming appointments is please bring your toothbrush or anything used to clean your toothbrush in between your teeth with
that's
you.
a brilliant idea.
And then basically they come in and then they have it with them. And then it's like, I'll hold the mirror. Right, you show me how to get that off. How are you doing it yourself? Yeah. Sometimes I'll get my DA in when I'm providing instruction. I'll say to the patient, do you mind if I loan your mobile phone? We'll take a video of you. The instruction I'm giving you, when you go home tonight, there's your video and it's only on your phone. It's not going to go to, be published in a magazine. So this is simply your individual message. And so then we'll give them toothbrush instruction. If they're missing it, I will say, can you hold the mirror? I'll show them how to do it. And then finally, I'll go have a go again. And then if they're still not getting it, I'll go, may I guide your hand? Obviously, as a man, I'm not going to grab a Muslim woman's hand directly. I need to ask consent. So I'll say, may I guide your hand? It's that haptic feedback mechanism. I can't tell you time after time after time, the patients go, it's that penny drop moment. Then look up at me. No one's ever showed me like this before. It's very individual.
It's always on the plastic models.
Yeah, it's on the plastic model. So if you put that model away, make the model the patient's mouth and then get them to touch, see, feel the difference. And this might be just 4 minutes at the start of the appointment. I'm not going to tell them to brush and then do the floss and then all the things. Incrementally put that in part of your treatment plan, which is the best approach. So and then positive reinforcement, they come back. Usually my own patients, they come back, can you do that back to your test? I want to see how I'm going. They always want to aspire.
Really like
they want to impress you. They want to impress you. So that's a good way. It's the positive reinforcement. Don't make them feel bad, but by putting on a disclosing agent, it tells a story. You don't have to go, you're doing a terrible job or make them embarrassed or feel bad. You just put it in front of them. And then if they realize, it's not great, you go, you know what? It's okay. I'm here to help you. It's okay. Let's fix it today. This is what we're going to do.
Nice. Very, very good. Very good. I mean, I really should try to change my oral hygiene regime as well.
Good way, even for your own, if you have hygienists, it's a good approach to train them with that. And then you do the OHI at the start of the appointment because you can connect it to the medical history if there's something applicable. And then after that, I would then prophylaxis, whether it's air powder polishing or a standard prophy, power-driven instrument, finish with the hand instruments and finesse.
So I think most dentists in Singapore are doing the OHI after.
Usually at the end of the appointment, you start to lose them. They think, am I going to go with my
tired
parking?
As well.
They're tired.
So,
and then if you do it at the start, then basically they're fresh and you've made the connection and you've talked about oral biofilm, that it's dental plaque as well, because usually that's what I have to say to patients. Oral biofilm means dental plaque. So when you're listening to commercials, it's now we call it oral biofilm. So then you're educating them as well and you make the relationship between any medical history that's present, it's fresh, and before they go, remember, go have a look at the phone tonight on the video we did for you, or just remember the tips I've given you. Or if they're doing a great job, keep up the good work. Barely any oral biofilm we saw after the bacterial test. You're doing great. Well done. Amazing. Keep up the good work.
That's great. I mean, but in terms of oral hygienists, in terms of like scaling and polishing and the regular stuff, what are the modern advances so far you've
generally, as I mentioned, air powder polishing is something we generally tend to teach the students now. And the sequence or the flow of treatment with that, no matter whatever brand you're using is, generally it's good to, as I mentioned, do the bacterial test, do disclosure, oral hygiene at the start, then do your air powder polishing first. Now, with your air powder polishing, make sure if you're using it towards the gum line, the powder in the machine that you're using is either a glycine powder or an erythritol powder, which can be used safely towards the gum line. There are other powders which can either be calcium carbonate based or sodium bicarbonate based. They should be directed away from the gum line. A good example, if you want to test whichever machine you have and whichever powder, look at the back, get a cherry tomato, get basically that super gingival powder. If you use it at a 30 to 60 degree angle, you will cut the skin of that cherry tomato. If it's a super gingival powder, most likely.
It's really abrasive.
It's quite abrasive. So always with a super gingival powder, basically it should say on the bottle or whichever packet it's coming into you that it's always angle it away. And there's lots of videos depending on which brand you're using, usually online on YouTube, or you go to the rep that sold it to you. Do you have any resources about the utilization of this powder and the angle? They'll provide it to you. And so identifying and being aware of the powder that you have is quite important. And then basically, if they've got lots of stain, I'll start, if they're heavy smokers, I'll start with that super gingival powder first, and then basically remove all of that. And obviously, because you've stained the biofilm or disclosed the biofilm, that's
You can see where you are.
see where
Everything.
it is.
Yeah.
And then you will remove the stain and the stained biofilm. And then if there's a little bit left, I'll then change over to the subgingival powders, a glycine or erythritol powder, for example, and then basically angle it towards the gum line. And generally, we can expect that could go usually around 4 millimeters around to the base of the long junctional epithelium. So that gives you the dentist clean feeling or hygienist clean feeling. And the patients love that. Then after that, your next workflow is generally go towards your power-driven instrument, like a Pison style, which most of the brands are these days. And then because you remove the biofilm, you're more easily going to identify the calculus deposits, particularly if there's a little bit of subgingival calculus, using your triplex to use air powder, basically the air to blow the floppy gingiva out the way. You'll see those specules of sub on the root surfaces. Use your power-driven instrument, move that. Then after that, I'll then move back to my hand scale as a posterior sickle, anterior sickle to go around if it's a standard cleaning case to finesse those last little bits and pieces, and it minimizes your hand movement, repetitive strain injury.
So and patients love it because
absolutely
the second part, the motor driven one, is a lot more not so nice compared to the
exactly. So also with your power driven instrument, try and set it usually around about a 30% mark. And the water is a fine mist, drip, drip, drip. But the reason we always do air powder polishing first is whenever we scale the teeth, we can create little micro cuts and lesions in the long junctional epithelium. So if you do your air powder polishing afterwards, you actually increase the risk of air embolisms in the gingiva. Particularly that's been documented historically with sodium bicarbonate powders. And that's obviously if a patient gets that, that's almost like that bubble wrap feeling in the gingiva.
It's like,
and this is where that's where the treatment for that is basically just reassurance. It's going to be fine. I'm going to prescribe you a course of antibiotics just as a prophylactic, just to make sure that if any infection did arise that you're covered. Then phone the patient the next day, the day after, usually the day, 24 hours, 48 hours, and they will find it sort of self-resolves generally. And also with the subgingival tips, if you're actually going down deeper under the gum.
That's quite dangerous sometimes.
That's definitely a glycine powder or an erythritol powder only, never with a sodium bicarbonate.
So rip everything apart.
Never with a supergingival, because you're going to hurt your patient. But if there's ever suppuration there, never use those subgingival tips because you can drive the infection further into and causes cellulitis. That's just sort of your power-driven instrument tip going down there and just down the elevator slowly up the fire stairs in terms of the stroke pattern.
And would you say that this technique is like the sort of the gold standard nowadays of
definitely. I think it's more emerging in the Singaporean market there now. I know they're just starting to teach at the Poly. I was teaching the students oral hygiene instruction at the Poly yesterday, and I was also visiting the students at NUS and doing a talk on oral hygiene around orthodontic and implants as well yesterday. And it's starting to emerge on the market here a little bit more in Singapore. So I think let's watch this space. There's a few new brands coming on the market, and it's something I think that's definitely worth of interest. So, but obviously, if you're not sure about that, approach the brand that which you're choosing to buy and see if they can come and give you a demonstration in practice, set up the machine for you, give you a bit of a lunch and learn so that you're confident in using whichever machine you're going to do.
So like we have like a lot of units. I wouldn't mention the brand, but we have a lot of units and patients love it. Like they love it because it's so painless. It's gentle on them and doesn't cause a lot of bleeding. And it's, I would say it's like drugs. I wouldn't say drugs, but it's very addictive. They're like, I just can't go back to my previous scaling and polishing. I really want to do this and this and this.
Usually a couple of the top level brands now, the water is warm. So it warms the water. And I know there's another new one coming onto the market here later on that's doing warming the water as well. That's sort of a bit of a gold standard they're aspiring to now, because in winter in Australia in particular, if you're in Melbourne, remember when you studied, it's pretty cold. And if you're doing your air powder polishing in Melbourne in the winter and the water's cold, you're not a happy patient, right?
You're not.
So that's where even what I'll do in Australia, because even with whichever brand, the elements still take around about 25 seconds to warm the water. Usually you either have it fixed to the tap as such, a direct line water supply, or you also have where you have a tank. Actually, you have the version. I have two different machines in my practice, one brand and another brand. But even though they're both really good at heating the water, generally what I'll do is still fill up with lukewarm water in the morning, so the patient straight away gets the warm water. That's a tip from me. But Singapore, maybe they might prefer a little bit more cooler water. It's not so much of an issue. You know what I mean?
The water's always warm.
Give you the cool water. But if they have any dentine hypersensitivity, that's where the warm water is definitely of assistance for those patients.
Actually, warm water is a big trick. Our chairs are also all warm water as well. So that's good. And then when patients like sip it, it's warm. It's
Yeah.
Because you're expecting like this shock of like sensitivity,
exactly.
right?
Yeah.
So it's really good.
No, that's good. Absolutely. Yeah. So no, I love the air powder polishing approach, and I think it's something that
I think it will change. Eventually it'll become the norm, I think. It'll be the norm.
It's a good thing.
Yeah, and that definitely helps with patients with braces as well.
Absolutely. The time and doing your conventional prophylaxis, then getting us dental brushes potentially, or even try the floss over the wire.
I don't know how you guys do it, man.
And the patients love it when you just use that air powder polishing. And again, disclose first, and particularly then do your OHI. With the particularly for a hygienist role more in this capacity, but get them to show the patient and explain to them you're missing here, and you've got to do the extra OHI around the braces for that, because I don't want you to have these braces off and you potentially have decay around where the brackets were. It's really important then, particularly if your mum and dad's paying and they're looking over the shoulder of the child, it's like you're going to cost an extra 5,000 Singapore dollars in restorative, are you? You know what I mean? So it's motivational factor in that sense as well. But powder polishing is a dream in these situations.
Yeah, absolutely right. Absolutely.
Yeah, it's a godsend.
Even in implants as well, I feel.
Absolutely. With the implant abutments, make sure it's either a glycine or erythritol powder to make sure you're not doing any air abrasion on your titanium implants if it's there.
Oh yeah. But you're right. It's for if there's any periodontitis, any infection, it's really, really, really quite nice. It's like you get a very clean surface finish.
Absolutely.
You can't do that with a scaler because you're just going to scratch it.
No, I mean there are some brands with titanium scalers now, but still it's better to not.
But it's hard because of fins and everything.
Exactly. It's better, and if the patients come in for regular maintenance, generally they won't get calculus formation around implant anyway if they're coming to see you regularly.
So just clean around
Absolutely, the area. Air powder polishing is good, and then make sure they're using a nice dental brush around there ideally, or even a water pick is good around implants. The evidence around water picks, basically, it helps to thin the biofilm and also irrigate away the bacterial toxins. So again, this is where I had a patient in Australia and he'd spent, I don't know how much money on a couple of all-on-fours, right, up around lower arch. Big investment. Wanted to use electric, but didn't want to use anything to clean around the implants. I'm like, this is not good.
Yeah, it is not good at all.
It's like I tried to size some dental brushes for him. He didn't want to do it. And eventually I got him into using a water pick. And that's helped to maintain the gingival health around there. And I said the evidence is, and the studies demonstrate, it will thin the biofilm. It's not as effective as a physical plaque removal. And I don't want them using floss around there because they have the potentially a bit of floss strand to get caught around even an implant abutment. And that could lead to a peri-implant mucositis, peri-implantitis. Don't want to do that. So an appropriately sized dental brush or a water pick, because then also it irrigates away the bacterial toxins produced by mature biofilm, which helps to at least establish and keep a fairly healthy area. So again, trying to pick that implement that a patient's finding acceptable, effective and non-traumatic, that actually going to be a part of their routine. And with water picks these days, you get rechargeable waterproof ones. So they could actually take it into the shower with them, which is already a wet space.
Otherwise, it's going to be really messy.
The upper arch, that's usually people hate that. You've got two types: the bench top, you're sort of hanging or leaning over your sort of bathroom sink, or these new variety now, which are rechargeable and waterproof, and you go into the shower. Much better in terms of patient acceptability.
Oh, great! Yeah. So your protocol for cleanliness is interdental brush first.
Yes,
and then
power-driven instrument. You could even use a hydrosonic style brush, for example, which is like the fishtail action style. Then you have the style which is also oscillating. The evidence with those basically, usually oscillating is ever so slightly better, and looking at most of the meta-analyses, like a Cochrane review, for example, on that. But basically, the hydrodynamic style is very good as well. But with that style of brush, it's important we teach our patient don't push hard with a hydrodynamic style brush, because if they push hard, they nullify the action of the actual
because it doesn't move so much.
That's right. So basically, you just want to touch it onto the area.
And it just wiggles.
What generates the movement of the saliva and toothpaste around the area, which can go at about 3 millimeters around the area looking at. So that takes a bit of touch to teach with your patient as well. So if I'm recommending that style of brush to a patient, I'll actually, with disclosure, show them and then demonstrate them. See, you can remove it without pushing hard. If you push hard, you're actually working against the action of the brush. So please be careful. So where if it's the other oscillating style, that's where make sure it's cupped at 90 degrees, and then you're going around the convex surface of, say, a buccal surface of a 3/6, and check their technique as well. Whereas the Hydrodynamic style, that's more like between a 45 to 90 degree pivot. It's a bit more forgiving. So that's usually, I'll recommend either brush around implant maintenance. But with the hydrodynamic style as well, it's been shown in people that maybe have a bit of autism, they have sensory issues, they generally tend not to like that.
It's like a variation, yeah.
But also, if you're recommending as a final point on the hydrodynamic style, always start, usually has a power range. Start them on a lower range because it's less intense. But then say every week, I want you to eventually step up, and try and get to the highest range. But you're going to get used to it. It's the most effective. Exactly.
Okay. Got it.
Yeah.
And in terms of bristles hardness, like for this electric toothbrush.
Yep. So generally we tend to go with the oscillating style. They have lots of different, depending on which brand you're looking at, but there's lots of different styles of heads, right? Ultimately, all the trials, or most of the trials, it's a soft bristle brush. So that is unilateral. Like even a manual brush, you want a soft bristle brush around 5,460 bristles or thereabouts. And just sort of look at that. And even the soft bristle brush for any of the electrics is what you sort of want as well, And encouraging our patient not to push too hard. And also, I know with one of the major brands with the oscillating, if you push too hard, they usually have some sensory, like a light.
I love it.
Or like there's the little thing which clips up on the mirror, unhappy face, And that's a good way to sort of teach the patient about the appropriate pressure as well.
In fact, I think in Singapore, given our more stressful climate, and people tend to brush very hard. So we get a lot of recession as opposed to plaque. Especially like where I practice in a CBD. That's where it's mostly recession, less plaque. Which is very interesting. So I have to tell them, hey, don't brush so hard. You gotta use the soft bristles and things like that. So it's the other way around.
Exactly. So you send them back to your hygienist and you give the instructions, disclose the patient, and then get them to bring their brush with them, and then prove to them that they can actually remove that stained biofilm with light pressure instead of pushing hard. But like my grandfather, for example, I could never convince him. He had big toothbrush abrasions and he would always use a hard brush. Sometimes we must admit it is very hard to break patients from that habit. They have that perception. If I don't brush hard, it's not clean. That's where, again, the disclosing or basically a bacterial test comes in, because you can identify and show them you can remove it without excessive pressure.
And again, the haptic feedback is so important, because only you know how strong you should push, or how weak you should push, right?
Exactly.
So if don't brush so hard, you don't really know how weak
is this getting it off or not? But seeing is believing. Seeing is believing, and that's where they go, okay, I get it. And if they need a bit more convincing, can say, go to any of the pharmacies, buy some of the plaque disclosing tablets, take it home, chew the tablet, spit out, and do it again. And then you can see for yourself that you can remove it with that light pressure without actually doing it as a positive reinforcement in the at-home place.
I think you can buy it over the counter. You can buy some tablets as well.
Exactly. I've been to most of the major pharmacies here in Singapore. Whenever I'm in any country, I always go and have a look at the dental products there. So, and I've pretty much seen them in nearly all the major I think it's about 3 big major chains here. So,
Okay, cool. So in terms of toothpaste, I would like to ask about toothpaste. What's the latest research so far?
Look, generally, it's still what we encourage with toothpaste as well is to swish, spit, don't rinse afterwards. Or so they actually retain the active ingredient behind. And I was actually, even at the IDEM conference, it was one of your specialist pediatric dentists was speaking, and she spoke about children's toothpaste. And now, even conducted in evidence here in Singapore, this is where actually, even for children with a small pea-sized or smear, up to 3 years of age, it's just that like grain of rice size amount of toothpaste.
That's really tiny. Yes.
And then over 3 or 4, because usually at that point they've developed this spit out mechanism. Prior to that, they swallow everything. But even what she was identifying in Singaporean-based research, and also she did a bit of a Cochrane review on that, was now there's more gravitation towards 1,000 parts per million instead of the 350 or 450 parts per million for children 3.5 to 4 years old. That's in a very small amount, because it has obviously the stronger fluoride content, which is having a better keriogenic protective effect.
And that's also like a pea-sized shape.
That's right. Okay. And that's what we recommend for adults. And usually the average fluoride you want content for a toothpaste for adults is the 1,450 parts per million. That's sort of, and again, you get a lot of people, what they do is they will rinse out completely afterwards. But what we want them to do is actually spit out. We don't want them to drown in toothpaste, don't get me wrong. But at the same time, we want them to actually have that taste behind. Because when they have that mild taste of actually the toothpaste, they're giving themselves a little topical fluoride application all the time. If they're not comfortable with that initially, essentially get them to rinse out, put a tiny smear on their toothbrush, brush around, spit out so it's a fresh bit, if that's what their mind needs, if they're worried about that. I will approach that page. And that's generally you can actually get the patient's sort of white spot lesions a little bit sort of resolved there in that sense with your topical application of fluoride varnishes, for example, or if I might need to recommend a calcium phosphate paste for them to use. And with those calcium phosphate pastes, the evidence now is you don't want to put it in a retainer because that actually needs activation with the saliva and oxygen for that to have its best therapeutic benefit, or a stronger fluoride toothpaste like a 5,000 parts per million, as long as they're keeping that away from children. We don't want them using that. It's too strong. So that's usually a recommend patients. If you've got young kids, I want you to put that on the top shelf so they can't reach it. And then again, a swish spit don't rinse element with that. So so that's sort of your main. And look, I think as we all know as well, if you're ever recommending a chlorhexidine mouth rinse, which is our gold standard mouth rinse for temporary use, if someone has a sort of a strong gingivitis, sodium lauryl sulfate in toothpaste can deactivate that. So you won't get the full therapeutic benefit from chlorhexidine mouth rinses if there's that foaming agent. So sodium lauryl sulfate's that foaming agent. So look around when you're going to the chemist, or maybe look to have some brands in your clinic that you know is sodium lauryl sulfate free. And if you need to recommend that, you want them to couple that up with a sodium lauryl sulfate free toothpaste if you're recommending a chlorhexidine based mouth rinse for that full therapeutic benefit.
And what do you think of hydroxyapatite toothpaste?
That's definitely
in thing now.
Yeah, actually, I'm actually working with one of the professors in Australia. We're actually looking to develop an all natural toothpaste. I won't mention brands or anything like that. It's still in development. We're about to potentially look at running a clinical trial on it. And actually, we're going to swap out fluoride for nano-hydroxyapatite. So nano-hydroxyapatite. And I won't go into the specifics, but it needs to be a specific crystal size. Think of nano-hydroxyapatite as like Tetris. Okay, so it needs to be a specific size for it to actually slot into the demineralized cube crystals within basically your enamel. It's like Tetris. So the evidence is...
It needs to fit.
And with nano-hydroxyapatite, it's good, provided it's the right size. Right? And that's something that's usually not identified on toothpaste because it's like an industrial secret for the particular producer.
So like it could be like the molecules could be very big or the crystals could be very large.
Correct.
And then it could be abrasive as well.
Exactly, in which case you know it's not going to be effective. So that's where it's trying to track down what the crystal size is. So it needs to be nano-hydroxyapatite. If it's just hydroxyapatite, usually it's too big, it doesn't really do much. The studies on the nano reveal it's almost equally effective as fluoride. And it's now because there's always this big scare around fluoride, right?
Yes, you're right.
So now with a lot of natural-based toothpaste, we're turning to go towards nano because actually it's an element contained within our bones and in our teeth anyway. So this is where it's perceived that's more of a natural element. But it's more costly to produce. So generally, if it's a really good nano-hydroxyapatite, the cost is higher, can be up to 25, 30 Singapore dollars a tube. But at the end of the day, even the toothpaste that I'm associated with, we're looking at a combination of herbs, vitamins, and other bits, which are natural, which with nano to basically use that in both a periodontopathic protection. So we're not trying to kill bacteria, we're trying to bolster the immune system. And use nano to actually prevent against caries.
That's really cool.
So there's some of those, and there are a few other brands that are emerging down that sort of line as well, where they're to look at that element of the market where they're looking more at a natural style toothpaste.
And I think they will appeal to a lot of patients because they're like worried about fluoride.
They're worried about fluoride, and overdoing it and that sort of thing. And we know it's a tried and true method, fluoride. We know that it's really good for anti-caries protection, but we're trying to find more natural alternatives.
What about kids though? Like
kids for nano?
Because that could be like a not a fluoride option.
No, so look, pardon me. So with nano-hydroxyapatite for kids, there's not really a lot of research with that. They've mainly conducted the studies on adults at the moment. So this is where, again, I would probably still stick with that tried and true method of fluoride at this stage. But again, even the recommendation that was given here in Singapore, generally, I think it's the Ministry of Health is backing that as well, where it's 1,000 parts per million over 3.5 to 4 years of age and just a small smear and get them to spit out but not rinse is your best sort of anti-cariogenic approach here in Singapore.
Okay, one last thing to pick in the travel bags,
exactly.
For kids. All right, I have 2 kids, right? And so
fantastic.
and then like I have to your toothpaste this flavor and that your toothpaste this flavor.
Yeah.
And like I got like so many.
Yeah, exactly. Dad has to set the rules.
And it's like 2 years old and it's like 4 years old, so I got to use two different toothpaste.
Yeah, exactly. Yeah, whatever it's like luring them into actually doing the brush, right?
Yeah, it's all about luring inside.
Yeah.
Okay, cool. So I think in terms of dentistry, where do you think the next 5 years is going to be like in terms of the level of dentistry and the standard of dentistry for modern care, for oral hygiene and
in terms of oral hygiene,
yeah.
I think definitely it's more moving towards this powder polishing in terms of biofilm. Oral hygiene, definitely, as we know, I think if you're looking for a brush, it's going to be either more electrics, but definitely tend to look for the softer. So you think
that electrics are a bit more efficient?
Excuse me. The evidence is electrics generally do tend to clean a bit better than manual brushes, but I'm going to go back to those 3 principles I was talking about before. What's acceptable, effective, and non-traumatic. For example, I have an elderly patient.
Yeah.
She's 82. She's been using a soft manual brush ever since she was a child. There's no recession.
Yeah.
She cleans her teeth perfectly well. If it ain't broke, don't fix it. So whereas if I have the unmotivated Australian teenage male, I won't say Singaporean teenage male, different demographic. Okay, unmotivated teenage male in Australia.
Yeah.
Okay, usually boys like toys. So generally I will tend to go, do you want to try an electric brush? And that will motivate them. What is going to motivate your patient to actually, what is acceptable? So
it's more like
to
the
them?
compliance rather than the actual tool itself.
Exactly.
Okay.
So being aware of everything that's on the market and potentially giving a recommendation to a patient. And look, being aware of your patient's social circumstances. If they're struggling financially, I'm not going to recommend the most expensive electric toothbrush.
It's very bespoke. Your treatment planning is very bespoke to that,
try and think about what they can afford, what's going on in their life, have a good understanding. If my patient's depressed, I'm not going to. I just want to get them to brush once a day if I can. So trying to look at them as holistically as a human,
rather than like, hey, just
just a
recipe,
mouse, just do it. This is best. It's like what's going on right now, and again, that's just us having a little bit of a conversation with our patients, and just sort of seeing how are you, what's been going on in your life. You don't want to delve too much in a personal way, but they might identify, my mother has just passed away. And you go, I'm so sorry to hear that. Showing it empathy.
And you don't want to be like, hey, you got to floss twice a day.
Yeah, exactly. Well, and if they say, I haven't brushed very much lately, you go, well, that's perfectly understandable. Obviously, you're really down. But, when you can, just pick any time of the day. When do you normally brush? I usually do it at night. But I'm like, no, well, then do it at lunchtime. Do it whenever it suits you, at the moment, just to look after yourself, and have a bit of a caring approach. But in terms of the way it's going, I think it's make sure that you, as an oral healthcare professional, go out into the supermarkets, the chemists, look at what products on the road, go to IDEM, go to conferences, go and see what latest developments are. And particularly even with restorative, look at the advancement AI is having with CAD-CAM, note-taking now. It's moving exponentially quickly. So I think the AI is not going to have a big influence on the manual oral hygiene product market, but I think if you're an oral healthcare professional, go to the trade shows, go and have a look, see what's new, speak to all the different booths, different brands, see what's out there, what could be recommended for your patients you think is going to be good, and check the evidence. If you don't have access to PubMed or any of those, even Google Scholar sometimes comes up with some good articles, which are open access articles, which you can use to reference to your patients as being good academic evidence for recommendations.
I would say like the last 10 years, dentistry has boom, it's there's so much technological advances now.
Absolutely.
And like the old school thinking of the patients are saying, hey, dentistry is painful and I have to do like manual scaling and polishing, things like that.
Yeah.
It's all gone. It's like, it's really, really up to date, right?
Yeah, exactly. It's changing. So, even if you're, it's good for you to attend your CPE courses here in Singapore, like for you guys as well as is in Australia, it's mandatory to have a certain amount of hours or points basically to retain your registration with the Singapore Dental Council, like we do with the Dental Board of Australia. So, and that is a good cue and a trigger for us to, pick a course where you think, I'm interested in that and that's going to benefit my demographic of patients, and by all means go to it, network, speak to your colleagues. What are you doing in your practice? Pick up some other ideas, keep yourself fresh. It keeps you fresh as an operator
keeps you
as well.
Motivated as well.
Because we get into our practices and we love our patients, but it can be a bit routine, and it's good to break that routine. Look for new ideas, get out there, do a few different things, and sort of see what's happening.
All right, thank you so much, Andrew.
Thank you.
It's really nice talking to you today.
Thank you so much for having me. I really appreciate it. Thank you.
Thank you so much. All right, I'll stay tuned for the next episode of The Bite Angle. Thank you so much.
Thank you.